What's up, Ninja Nerds? In this video today, we're going to be talking about ascites when that abdomen is super big and super distended. This is a part of our clinical medicine section. I really hope that you guys do like these videos, and I hope it helps you and it makes sense. And if it really does, I think one of the ways that you guys can support us is by hitting that like button, commenting down in the comment section, and please subscribe. It really goes a long way. Also, for your better education, for your understanding of these topics, I really highly suggest go down the description box below. There's a link to our website. On there, we have a lot of amazing notes, a lot of great illustrations. On top of that, we're even developing quizzes and exam prep courses. So there's a lot there to offer. Please go check it out, take a look, and see if it's something that interests you. All right, without further ado, let's talk a little bit about ascites. That abdomen, too damn big, man. So when we talk about ascites, it's this fluid-filled peritoneal cavity, if you will. We have to kind of go through and say, what are the reasons you develop this fluid, lots of it within the peritoneal cavity? What is the pathophysiological reason? And then also let's talk a little bit about some of the classic findings that you can see in these patients. All right, so first things first, you can really pathophysiologically break them down into two phenotypes. One is the transudative type of ascites, and the other one's the exudative type of ascites. Transudative ascites is usually a little bit more related to pressures. And what I mean is it's related more particularly to portal venous pressures. So let's talk a little bit about this. So let's say that the primary problem in transudative ascites is that the pressure that pushes fluid and other small things out of the actual capillaries into the peritoneal space here is basically related to the portal venous pressure. All right, so what I'm going to say is that this patient has elevated portal venous pressure. And the patient who has an ascites related to a transudative pathophysiology. All right, so if the portal venous pressure is high, what happens is, imagine here's your portal vein. This is going to cause this to be transmitted backwards into, like, if I zoom in on the portal veins that are around the peritoneum. Let's say here, this space here, right here, is your peritoneum. So here's your peritoneum. And then here is going to be a capillary. So here I'm going to point out this is a capillary, and it's like a portal venous capillary. When the pressure inside of this capillary is very high, it's going to cause the movement of molecules and water to move out of the capillary into the peritoneal cavity, right? So the things that are leaking out of the capillary into the peritoneal cavity is what? That's a great question. It's primarily water, right? So let's represent that by these like blue dots. It's primarily water that's going to leak out. Maybe some electrolytes of other specific types as well. Now, the thing that could leak out, but it's in very small quantities, is proteins. And I'll represent this by these like darker blue dots. This is albumin. We're going to use the most common serum protein, such as albumin. Now, why is this important, and why, Zach, are you harping on this concept of there being lots of fluid that leaks out, electrolytes, but only a little bit of protein like albumin? The reason why is when we take, and it's always suggested in patients who have like new onset ascites, you go in, you pull some of that fluid off, send it to the lab. And usually what will happen is the lab will give you something called a serum ascites albumin gradient. Okay? Now, what this does is it says it's basically related to your serum albumin. So we're going to say there's a two-part to this. The serum albumin minus the acidic albumin. You probably see where I'm going here. Now watch this. What I know about all of these types related to the high portal venous pressures. If I stick a needle in there, pull some of that fluid off, send it, the sag for high portal venous pressures or transudative ascites is always greater than 1.1. That's always the case. Now, here's what I want you to think about. That's a bigger number. Serum albumin in these patients is not usually the problem. We're going to say that this is like somewhat, let's say, normal. But here's the real issue. What did I tell you about the acidic albumin? Is it a lot or is it a little? I said it's very little. So if I say very little of this albumin is acidic, I'm taking a constant number and subtracting it by a very tiny number. What happens to the overall number? It's relatively larger. And that's where this sag comes from, is that the serum albumin isn't the problem. I'm losing very little, I'm having very little amounts of albumin in the ascites. That's the big difference. And this is usually, whenever you say a sag greater than 1.1, you think about high portal venous pressures, a transudative ascites. And then you gotta be like, oh shoot, all right, what's the cause of the ascites? All right. Then we gotta focus our eyes into a schematic here and say, is the obstruction that's causing this back pressure to be high after the liver, in the liver, or before the liver? So post-sinusoidal, sinusoidal, pre-sinusoidal. Let's go in order. If it's before the liver, it's some type of obstruction in the portal vein. You know what this is? This is it's not very common. I'd say it's probably out of these one of the least common ones. But it is a potential etiology, and it's called portal vein thrombosis. If you got a clot in there because you have an underlying hypercoagulable condition of some sort, then what's going to happen? It's going to clot this off, and it's going to cause the back pressure to increase, proximal to that occlusion. If you have a sinusoidal obstruction, something in the liver, let's say a patient has a disease called, and I'd say it's by far the most common cause, cirrhosis. So their liver is fibrotic as all crap. And what it does is this fibrosis compresses on all these like architectures here. It compresses on the hepatic veins, it compresses on the portal veins, but more particularly the portal veins. Imagine them compressing on some of these smaller vessels. Am I going to be able to get blood flow through the liver out into this inferior vena cava eventually? Not very much, so the back pressure will increase. So by far the most common cause of a sinusoidal or intrahepatic cause is going to be cirrhosis. And I think it is important to remember that this is by far going to be the most common one. All right, especially for portal hypertension or transudative ascites. The last two are also important to remember. I would say that, again, not as common, but definitely think about it. If I have an obstruction right here in these veins, they're coming out of the liver, or I have a back pressure coming from the inferior vena cava from the right atrium. So let's say here, I'm just going to say here's my right atrium, and the central venous pressure is high. What's that due to? Right heart failure. So if a patient has what's called right heart failure, where their central venous pressures are really high, that's going to cause a backflow, and it's going to congest this hepatic veins and prevent blood from going backwards, or going forwards, and then it's going to cause this back pressure to increase. If I have a clot within the portal veins, a clot within the hepatic veins, then I can't get blood to move through the liver and not into the inferior vena cava eventually. And then the back pressure will rise. What could that be due to? It's an interesting disease, again, similar to portal vein thrombosis, and it's called Budd-Chiari syndrome. And this one is usually something that you would see in a patient who has hypercoagulable kind of states, malignancies of some sort as well. So think about that. These things cause obstruction within the flow of blood through the liver into the inferior vena cava at some point. Portal venous pressures rise, fluid leaks out, more water, more electrolytes, very little albumin in the ascites. So if you look at the sag, it'll be high, greater than 1.1, points you to this, and then you think about these causes. Now, you're probably like, okay, I got an idea of like the small diagram, but what does ascites truly look like in this patient then? Well, if you think about it, if we were to zoom in, see how this cause, or zoom out actually, you'd see this is going to be the anterior portion, posterior portion, this is their big belly, and you can see they're going to have all this fluid accumulating in their belly, all right? And we'll talk about some of the classic findings in this patient in a little bit. Before we do that though, we got to say there's another potential cause of a patient developing ascites. I'd say it's definitely less likely. When you think about the three most common causes of patients developing ascites, it's CHF, cirrhosis, and cancer, the three C's if you really want to remember that. But when we talk about it with respect to exudative, it's not pressure, portal pressure related, it's two things. One is you have less albumin. Here's a disease. There's two things. You can either lose protein from your gut. It's super rare, protein losing enteropathy, but it is a little bit more common to have protein loss from the urine. We call that nephrotic syndrome. Now, in nephrotic syndrome, you pee out a ton of albumin, and therefore, I'll represent the albumin. I did this kind of darker blue color. Ton of albumin in the pee-pee, right? That means that the amount of albumin remaining in the bloodstream is lower. So as a result, I'm gonna have a low, we gotta be specific here, fam. This is a low serum albumin. This is basically the protein that is inside of the bloodstream that's supposed to kind of help to maintain a degree of oncotic or osmotic pressure, right? If I have less of him, what happens to my oncotic pressure? It drops like a son of a gun, right? And if this drops, oncotic, osmotic, it doesn't matter. Pick your poison on this one. It's not that big of a deal. But the concept is that you're supposed to keep fluid into the bloodstream. Is that going to happen? No. And so in this scenario, you won't be able to keep fluid into the bloodstream. And so what will happen to that fluid? It'll leak out. So you'll have lots of fluid that's going to be rich in water and electrolytes, and there is even going to be some albumin in there too, right? Okay, cool. All right, before I move on to this, next concept of the SAG, there's also another one, capillary leakage. So in this particular scenario here, the capillaries have holes in them. They've become very porous. And if they're very, very porous, fluid loves to leak on out. And it doesn't matter what kind of fluid. It could be water, because these are some big old holes. And so lots of water and electrolytes, and what else? What's big enough now that it can actually start leaking out? Proteins. And what do you think is going to be the main protein that starts leaking out there? Albumin. So what will you have a lot of out here? Albumin. So you're probably starting to get this, right? Nephrotic syndrome, you lose lots of proteins in your blood. Capillary leakage, you lose lots of albumin in the ascites. So watch how this works out into the formula. Question is what's causing these capillaries to be super leaky, right? It's usually malignancy. Heck of a name here. But it's called peritoneal carcinomatosis. Oh my gosh, look at that meme, man. Usually, this is seen in cancers that have seeded to the peritoneum. You know which one's the sad one? And it's usually, unfortunately, the last way that they present is ovarian cancer. Usually these patients get really, really big and bloated, and it's usually they're at stage 4 when it's already seeded to the peritoneum. But that's one. Another one is infections. I think the big one, you probably don't see it all that often, but it's something to keep on your radar, especially if the SAG comes back, as we're going to talk about, to think about tuberculosis. And the last one is inflammation, all right? So usually this is sterile inflammation. It's not an infected related inflammation. And what's that one organ that sits kind of like right behind the stomach, gets angry whenever you drink too much alcohol, you get some gallstones? The pancreas. When the pancreas gets inflamed, man, that sucker can leak so much fluid into the actual peritoneal space, and you can get a pancreatitis. You can get a lot of ascites with this one. All right. So with that being said, with these, they're causing what it says, the capillaries to be super leaky. And then you'll get this process. Whereas the oncotic pressure, if it's really, really low, you're not going to be able to keep fluid in. Now think about this. Go in, pull the fluid off, send it to the lab, and I get my SAG. Let's actually bring this over a little bit more because I feel like we're going to run out of some space here. Here's going to be my SAG, serum acidic albumin gradient, equal to serum albumin minus acidic. Oh man, Big Daddy was right. We are going to run out of space there. Acidic albumin. Okay, with this being said now, in nephrotic syndrome, what happens to the serum albumin? Drops, okay? In capillary leakage problems, what happens to the serum, the acidic albumin? It goes up, right? So this right here, again, this is going to be, let's actually say that this one here, this protein, we're looking at it in this sense. This is all the albumin that's sitting in the ascites. That's going to be up. Regardless of which one is which, let's pretend, keep this constant for a second. In nephrotic syndrome, low serum albumin, constant here. You're taking a small number and subtracting it from like somewhat of a big number. What's going to happen to your overall number? It's going to be lower, right? And we'll say that in this case, it's going to be less than, what do we say? 1.1. 1.1. And I did it like this. In the capillary leakage problems, the acidic albumin is high. Block this, keep this constant. You take a normal number and subtract it from a really big number, what are you going to get? A smaller number. So you see how the SAG comes out, you tap in, you get an idea of which is the potential cause. Is it exudative or transudative? And then you think about your etiologies. Now when a patient comes in with ascites, you have to then say, okay, what's the classic presentation? And I think the big things to remember here is there's 3 specific findings. One is super obvious. You got something in the abdomen that's not normally there, it's going to be bigger. So distension, if you will, of the abdomen. Second one is whenever you kind of have these patients, the fluid's kind of somewhat mobile unless it's loculated or, kind of like pustule, like if you lay on one side, what do you think this fluid is going to move to the gravity-dependent side? So it'll shift. If I were to tap on the one side, it would be tympanic, which it normally is. But on the other side, where all the fluid moved to, it would be dull. So you'd have what's called shifting dullness. Lastly, in this patient, if I were to tap, so this is all kind of like tests that don't have a lot of sensitivity, but think about it for exam, you tap, fluid can kind of conduct some of that sound waves that is generated from tapping on the abdomen to the other side. And so if you tap and you feel the fluid wave that can be palpated on the other side, the hand here, tap, and you feel the actual fluid like moving to the other side on your hand, that's called the positive fluid wave test. These things would be suggestive of ascites. By far, if you get a test question or in real life, which is going to be the most likely cause, it's going to be cirrhosis. All right, but think about the 3 C's, cirrhosis, cancer, CHF. Now let's talk about the complications. All right, my friends, so the patient who has ascites, they got a big abdominal distension, they got some of those positive signs of, shifting dullness, fluid wave tests. You're thinking, okay, they definitely could have ascites. You go, you tap into it, you send off a sample to the lab, it comes back with a SAG gradient, which will tell you, it's a transudative, it's an exudative type of ascites. Those are super helpful. And I think that can kind of take you down the diagnostic steps that we'll talk about a little bit more detail next. But I think one of the things that you really want to be careful for is we talked about the 3 most common causes that you really want to think about for ascites, and that's cirrhosis, by far the most common, cancer, and CHF. But with that being said, cirrhosis is by far the most common one. And usually something that can happen in patients who have ascites is they can infect that ascites. And that sounds weird, right? But it can happen. It's called spontaneous bacterial peritonitis. You're like, what's the difference between spontaneous bacterial peritonitis and peritonitis that's seen in like appendicitis or other diseases? Well, those are secondary bacterial peritonitis. In other words, it's some type of disease of a GI organ, let's say of the appendix, that ruptures and causes bacteria to spread, right? In this particular situation, there's bacteria that's actually present in the actual peritoneal fluid, and then it causes infection. And that's what's really interesting here. So we got to talk a little bit about that. So let's say by far the most common one is going to be cirrhosis. So with that being said, cirrhosis we said was causing sinusoidal obstruction. There was all this fibrotic tissue that was occurring, and it was compressing all the vascular architecture of the portal venules. And then by default, what happened? It led to the pressure backing up here being really, really high. And I'll represent that with a P here. So there's going to be an increase in the pressure. What type of pressure? The portal venous pressure, right? Because this is, what's this guy right here? This is called the portal vein. So this is called the portal vein right here. And what happens is the portal vein will actually kind of pick up nutrients and other types of materials from the GIT via what's called the superior mesenteric vein, which will represent here, the inferior mesenteric vein here, and then you have other ones like the inferior gastric and splenic veins, which come over here. But right now, I want you to understand that this portal venous pressure causes the pressure to back up in these smaller portal veins, and then what do we say happens? The pressure, when it's higher, causes fluid to leak out. This is that transudative type of ascites. So when a patient has cirrhosis, which is by far going to be the most common cause of ascites and really the most common cause of spontaneous bacterial peritonitis, which is very helpful, this will lead to, again, obstruction within the sinusoidal level, increased portal venous pressure, and then fluid, which is rich in water, electrolytes, but not a lot of albumin. Remember I told you that, and that's why the SAG for these are greater than 1.1 because they don't have a lot of acidic albumin. So we'll represent that here with the blue. This is all the blue. There's not a ton of this acidic albumin, right? So there's our ascites. So now we have a patient who has ascites. We already talked about that, but here's the big thing. In a patient who has cirrhosis plus maybe an upper GI bleed. So we sometimes see this in cirrhosis plus new onset ascites. You have to be thinking about SBP. If for whatever reason they develop an upper GI bleed, if for whatever reason they've had a history of prior SBP episodes, that definitely increases the risk of developing SBP. But here's what's really interesting. The concept behind this is that you have bacteria that are a part of our flora. So there's this theory that you have bacteria within your GI flora here. And then what happens is some of these bacteria, usually the same type, it's usually monomicrobial, it'll spread from the GI lumen and it'll go to the nearby mesenteric lymph nodes. And then from here, it'll spread into the actual acidic fluid, into the peritoneum. So bacteria will go from here, across the lumen, into the mesenteric lymph nodes, and then into the actual acidic fluid. So now I have bacteria that is accumulating inside of this acidic fluid. Now here's the interesting component. If within this acidic fluid I have a couple different things. I have protein, I have other types of like fluid and electrolytes, but I have bacteria. That's the really big thing here, right? So let's say that here I have bacteria, which is the one big thing. The acidic fluid is another big thing, but there's one more component. So there's going to be bacteria. There's going to be increased acidic fluid. What's the other big thing? Watch this. When bacteria are present here, they're going to start causing a little bit of inflammation of the peritoneum. So this peritoneum is going to start getting a little bit angry by the presence of the bacteria in this peritoneal space. So they're going to get a little bit angry. And when you inflame a tissue, you're naturally going to trigger the production of, trigger the production of cytokines. So small amounts of cytokines can be released into the circulation. What are these? Cytokines. These cytokines will then attract into this area immune system cells. But the most particular ones that we're going to see is the polymorphonuclear leukocytes. You're like, what in the? That's just neutrophils, man. That's all it is. I know what that is. So you're going to get lots of these neutrophils, right? Now, what these puppies do is they'll move to this area and they'll infiltrate and move into this peritoneal space to try to go and kill all the bacteria and clean up some of the area here. And so what you're going to get is, you're going to get some cytokine kind of alarms going off. They're going to then do what? These cytokines alarms are going to stimulate these white blood cells, polymorphonuclear leukocytes, who will then infiltrate into this area. And so now what else am I going to have in this area here? I'm going to have PMNs, or neutrophils if you really want to be more specific in that kind of sense. So here I'm going to have PMNs, or neutrophils, in combination with the bacteria in the acidic fluid. So the PMNs. And we're really particular in medicine, and we say it's really got to be particular in the sense it's greater than 250 of these cells, 250 of the PMNs per millimeter cubed of acidic fluid. If I were to tap into that fluid, test it, I get some bacteria, but the more particular thing that's really helpful is the PMNs. And this is super important to remember, okay? The other thing that these cytokines do is that they also alert what else? Your hypothalamus. And if you alert the hypothalamus, what's that going to trigger? An upregulation of the body temperature. And so these patients will also develop a fever. Right? This is very straightforward kind of concepts here. So you're going to get an increase in the amount of neutrophils that infiltrate into this area. You're going to get a fever. You're going to have this acidic fluid, which is rich in bacteria that kind of migrated from the lumen to the mesenteric lymph nodes into the acidic fluid. What else? Well, the other thing is pretty straightforward. It inflames the peritoneum. So therefore, they are going to have what? They're going to have peritonitis. And so some of the findings of peritonitis is they may have very significant abdominal pain. Maybe they have a little bit of rigidity. Maybe there's a little bit of guarding. Maybe there's some tenderness to palpation. But I think one of the biggest things is to really watch out for that abdominal pain, my friends. So if they got some really bad abdominal pain and potentially some signs of peritonitis, such as rigidity or guarding or rebound tenderness, right? That is really, really helpful and can be suggestive. So watch out for abdominal pain, plus rigidity, plus guarding, and rebound tenderness. So if a patient comes in, they have a history of what? They have a history of cirrhosis. They have, on top of that, new onset ascites. It is within the guidelines to tap into the fluid. If you tap into the fluid, you send it off to the lab, it'll tell you there's an acidic fluid that is more specifically suggestive, likely of a SAG greater than 1.1, all right? Bacteria, that's usually monomicrobial, and lots of polymorphonuclear leukocytes. We've already explained that mechanism. They'll have a fever due to the cytokine release, and they'll have local features on their abdomen that suggest peritonitis, abdominal pain, rigidity, guarding, rebound tenderness. And this patient, you really want to think, do they have SBP? That could be a complication that we can see in ascites, but specifically in those patient populations with portal hypertension related ascites, likely due to cirrhosis. Now that we've covered that, let's talk about how do we go about diagnosing ascites and the types of ascites. So we think about ascites in the two forms, SAG greater than 1.1, SAG less than 1.1. We talked about SBP as one of the biggest complications as the result of ascites in a patient with cirrhosis. How do we approach ascites? Well, oftentimes we would see these patients, and what we would do is once we say, oh, they got a distended abdomen, they got a positive fluid wave test, they have shifting dullness, and I think that they have a history that suggests that could be ascites from a transudative or exudative process. I got to get an ultrasound to really say, okay, do I have true evidence of ascites? If you do an ultrasound, you can see here, look, here's bowel. All of this is bowel. This is the abdomen wall, and then all this dark kind of area here is the acidic fluid. And that's definitely indicative of ascites. You could also get an abdominal CT scan if you needed to. And here's the liver. And you see all of this dark area here. This is all acidic fluid. And so again, if I have evidence of my physical exam suggesting ascites, and then radiographic evidence of ascites, I then can say with full confidence, this patient has ascites. I just don't know which type. So then what you can do is you can say, okay, I got ascites. You have to ask yourself two questions. Is this ascites new? And is this a patient who has cirrhosis and they are being hospitalized? In these two scenarios, if that is the case, you have to do a paracentesis. If it's new onset or they have a history of cirrhosis and they're being admitted into the hospital with ascites, you have to tap that area and pull off some acidic fluid and test it. If you do that and the SAG comes back at greater than 1.1, that tells me, okay, that means that the ascites albumin is low. That's portal hypertension related. That's transudative effusions. If I tap it though, and I say, oh shoot, the PMNs are coming back really high. Well, polymorphonuclear leukocytes, that was a complication whenever a patient had SBP. Oh shoot, so this is portal hypertension, probably from cirrhosis, which is the most common cause. They developed ascites, then they had bacteria that translocated, caused neutrophils. What if their cultures are positive? Oh my gosh, this is an infection. This is really bad. This is SBP, and they need antibiotics. The other way I could look at this is, okay, I get a SAG. It's less than 1.1. Right away, okay, less than 1.1, that's the weird one. That's whenever either they have hypoalbuminemia from nephrotic syndrome, or they have a really high ascites albumin, and that's going to drop down the overall SAG number. So I know it's exudative. It's non-portal hypertension related, synonymous there. So then I have to kind of dig a little bit further. I have to say, is this a really significant capillary leakage problem, or is it a hypoalbuminemia problem? How do I figure that out? I look at the acidic fluid total protein, and if it's greater than 2.5, that tells me it's likely more of a capillary leakage problem like TB, or like malignancy, or even pancreatitis. If the acidic fluid total protein is less than 2.5, it tells me it's not a capillary leakage problem. It's probably more hypoalbuminemia like nephrotic syndrome. That's pretty cool, right? Now, what if I get a SAG greater than 1.1, but the PMNs are less than 250, so I don't think it's SBP? I definitely have to say with this scenario that it only means that the acidic albumin is low. So it has to be portal hypertension related. It's all hydrostatic pressure pushing fluid out. That's not a lot of albumin though. Okay, well then I have to think about this. Okay, I know that this is either due to a pre-sinusoidal, a sinusoidal, or a post-sinusoidal obstruction. Okay. Well, the two big things I have to determine is it cirrhosis or is it not? And that's the most important thing. So what you would do is you would say, okay, what's the acidic fluid total protein? If it's greater than 2.5, what that tells me is that the actual circulation has at least some degree of albumin present in it, a little bit more. And it has more protein in it. You know, whenever patients have cirrhosis, they don't produce enough proteins, and that includes albumin. And so if the patient has a little bit more protein, at least total protein, in the actual ascites, it tells me that they are able to produce proteins from their liver. So I doubt that they have cirrhosis. So this is probably more right heart failure, more Budd-Chiari, more portal vein thrombosis. But if the amount of protein that's present in their ascites is actually a little bit low, the total protein, that probably tells me that their liver is probably not working well and it's not producing in as many proteins as it should be. So that means that this could be cirrhosis. So this is a little bit of a way that we can utilize this to help us to understand the underlying etiology of the ascites. Okay, I think the big thing to remember though is this portion here. What's the SAG? And then use the acidic fluid total protein to help you to differentiate more. Oftentimes though, history is a little bit more helpful than the acidic fluid total protein. But again, in this scenario, think that there's not a lot of proteins being produced by the liver. In this scenario, think that there's not a lot of proteins present inside of the bloodstream because you're peeing it out, right, in the scenario of nephrotic syndrome. All right, how do we treat ascites? Well, it really just depends. Oftentimes, if it's an exudative ascites, it's about treating the underlying cause. But with transudative ascites or portal hypertension related ascites, there is ways of treating this because we know the mechanism behind it. And oftentimes the first line is restricting sodium to less than 2 grams, but this is a really good medical combo that we oftentimes use. So let's actually take a second to understand this. In patients who have underlying portal hypertension, whether it's post-sinusoidal, sinusoidal, or pre-sinusoidal, either way, they're having portal hypertension. What that does is your liver makes little vasodilator molecules to try to dilate the portal vein. Problem is it dilates a lot of your other splanchnic vessels and pools a lot of the blood in your splanchnic circulation, so in your bowel area, your GI tract. Problem is that then your sympathetic nervous system thinks that there's not enough blood in your actual general circulation. It says, oh crap, I gotta amp up my renin-angiotensin-aldosterone system and squeeze the blood vessels and really resorb more sodium and water so I can have a better blood pressure. And so that's what it does. It actually tells the kidneys to really intensely vasoconstrict to conserve that volume so we don't pee it out. And it also causes it to release renin, angiotensin. It causes it to release renin, which leads to the formation of angiotensin 2 and aldosterone. With angiotensin II and with aldosterone, what you're going to do is you're going to vasoconstrict the blood vessels to increase your blood pressure, but you're also going to cause aldosterone to do what? It's going to reabsorb more sodium and water, which increases your blood volume, but unfortunately it leads to more sodium and water retention. You know what happens when you retain more sodium and water in a patient with ascites? You worsen their ascites. So the whole concept here is, what if I give them spironolactone? And if I give them spironolactone, I'll block aldosterone. Aldosterone won't reabsorb as much sodium and water, and I won't worsen my ascites. Well, that's pretty cool. The other thing is what if I get rid of some of the excess sodium and water out of the body with furosemide and I have them pee that out? That would also benefit from reducing the ascites. So both of these are mechanisms that we can use to reduce the actual development of ascites. All right. The next concept here is, what if a patient is on spironolactone, furosemide, and we're utilizing this and restricting sodium, but unfortunately they develop a really large volume of ascites here. And it's unfortunately not something that's going to respond to just your usual medical therapy. Well, then we have to stick a catheter through the abdominal wall into that space of ascitic fluid and drain that fluid off. And we use this term large volume paracentesis. This occurs when you pull more than 5 liters off. So if you're pulling more than 5 liters off, it's a large volume paracentesis. If you're not pulling off that much, then it's just a normal paracentesis. We don't consider it large volume. The reason why I'm really stressing on this concept of large volume paracentesis is when you pull off more than 5 liters, you really could deplete the patient's albumin. So you have to give them some of that albumin back. So if you take off more than 5 liters, you have to give them albumin back. And that's really important to remember for treating these ascites. All right, so you've done medical management with spironolactone to reduce aldosterone, furosemide to get rid of a lot of the sodium and water, the excess amounts. If they have a large volume paracentesis, make sure you give them albumin. What if they've on medical therapy, they're getting frequent paracentesis, and they're still having ascites? Then you should then see if they're a candidate for the TIPS procedure. This is a transjugular intrahepatic portosystemic shunt. They go through the internal jugular vein, they run down through the right atrium, right ventricle, or right atrium into the inferior vena cava, down into the hepatic vein, and they put a stent that extends across the hepatic vein and into the portal vein. And what that does is that allows for blood to completely bypass the portal vein and go right from the portal vein right into the hepatic vein. So it kind of bypasses all these other areas of where there's a lot of fibrosis and compression of the smaller venules and where there's a lot of high pressure circuits going on. So this is a very helpful tool to be able to use in patients with refractory ascites. All right, my friends, that covers ascites. I hope it made sense. I hope that you guys enjoyed it. And as always, until next time.